Hey, this is Dr. Livingston, and here is our lecture on assessment of somatic related disorders. So here's our list that we're going to go over. We're going to add our diagnostic criteria for conversion disorder and factitious disorder also. For this grouping of disorders, we want to remember that the common feature of all of them as to why they are grouped this way in the DSM is they have the common feature of the prominence of somatic symptoms associated with significant distress and impairment. Now, the focus for the patient might not necessarily be on the symptoms or the potential disease, but rather how those symptoms present, and then also how patients interpret those. Sometimes we can explain the symptoms through either a medical or the psychiatric related manifestations. But oftentimes we are unable to find a source for the symptoms that patients present with. Um, and so when that happens, then that's what's going to kind of lead us in this direction. Now let's look at our little list of assessment and diagnostic tools. So here is the few that we have. Most of these we're going to be using just simply to assess the presence of and then level of severity of symptoms within the clinical setting. Let's look at some of those specifics about assessing these types of disorders. So now let's look at how we're going to go about evaluating and assessing our patients kind of ahead of time. So first of all, it's good to know that you know it is very common for patients with these disorders to be referred from their primary care or from another medical professional, but they also might present to our offices with symptoms of depression or anxiety, and we just kind of happen upon symptoms that meet criteria for these disorders. So because of that, it's going to be really important that we obtain rather a detailed list of all medical providers as far back as we can go, and also request those records. We want to make sure that we get primary care, especially if they've changed, any specialists, emergency room, or walk-in acute care clinics, all of those types of things, because it's going to be very important to uh, review those records so that we can assess sometimes the validity of their somatic complaints. And we'll kind of talk more about that in a minute. But really, we want to see what symptoms they have presented to medical providers with, and what were the assessments completed. What kind of testing and evaluation for from a medical perspective has been completed. Another reason that we want to look at these is because we have to take into consideration that simply because a lab value or a test result is considered within normal limits does not necessarily mean that that is normal for the patient. I always think about TSH, thyroid function, when talking about this. And that's because there are some people that, if their TSH is historically on the lower end of the scale, that lower end of normal, well, mild elevations can cause problems and vice versa, but still remain within normal limits range. So we just want to be able to look at those. We also want to get this list of medical providers because we will want to consult with initially and maintain communication with their primary or with their medical providers. And that is going to be especially true for primary care providers. Some of these disorders we have to coordinate care very carefully, and we will talk about that in 543. Um, but just know that these are not disorders that we're going to treat alone. We're definitely going to require a team approach. Now, there are quite a few goals to our assessments for this grouping of disorders. First off, we want to be able to confirm that the symptoms that a patient is experiencing are not based in any type of medical pathology or pathophysiology. This is kind of key to identifying these disorders. If something, if if some of these symptoms do have an actual base in, uh, you know, medical conditions or a medical process going on, then it could, not always, but it could rule out some of these disorders. Um, Along with that, once we confirm that they're not a medical basis, um, then we want to identify if there is a psychopathologic basis for these symptoms. We're going to want to develop a treatment plan that does include a medical team, or the patient's medical team, rather. And then we also want to focus on alleviating the patient's anxiety surrounding those somatic symptoms and or their concerns of new or ongoing medical conditions. And then we definitely want to make sure that we have ruled out and or identified cases of factitious disorder and definitely of malingering. We always have to rule out malingering. Um, Now, in some cases, I didn't add this to this slide, but we do have to keep this in mind. In some cases, insurance might actually want to assign a case manager. That could be a thing to make sure that we're not, or that these patients are not excessively utilizing unnecessary services. Some other involvement, let's say areas of involvement, agencies, could be legal resources, protective agencies, maybe even a patient advocate. And worst case scenario, we might have to actually involve law enforcement agencies. And we'll talk about kind of when that might happen here in a minute. So, as much as all of that process, procedural aspects are of utmost importance in this grouping, we also have to make sure that we're asking the right questions so that we get the information that we need. So one of the first things, and again, hopefully this is kind of clicking with you guys because this is going to be a repetitive type of thing, timeline. We have to see that timeline and figure that out. Sometimes a timeline can give us um, a lot of information of just um, what's been going on in a patient's life and how that correlates to their development of symptoms. And for these disorders, this is especially true because a lot of times we can see that medical conditions, certain life stressors, things like that, can actually be a precipitating factor to the development of some of these disorders. Along with that, we want to assess our patient's perception of their symptoms. Um, there's going to be plenty of times that a patient is, let's say, they come in because they have a lot of anxiety and they fail to tell us about GI upset, GI symptoms rather, that they have because they believe that that's a medical thing. Those are medical symptoms because it's your stomach, it's not your brain, it's not your feelings. So when we have the opportunity, because we've asked those questions, to say, actually, what does your medical provider say? What does your PCP say about your GI symptoms? And a lot of times we might hear, well, they don't really know why that's happening, or there's some vague, uh, broad category of disorder, such as like IBS or something like that. Um, well, if we know that, then we can provide a lot of education and say, well, a lot of GI symptoms are what we could consider physical manifestations of anxiety, and provide that education that way. Now let's look at those couple of new diagnostic or new disorders diagnostic criteria that we're adding this semester, and look at a couple of other important aspects of these disorders.
Conversion disorder is a very interesting disorder. Um, it's also known as functional neurological symptoms disorder. Um, and this is basically we have a physical manifestation of some sort of psychological distress um, that, of course, then creates functional problems. Um, there's not a medical explanation for why this symptom or disorder or dysfunction is happening. Um, Now, that doesn't necessarily mean that there's nothing medically that's causing it, but um, there doesn't seem to be a physical or medical etiology to it. Um, and we'll talk more about this disorder a little later in this lecture. Now we've got specifiers, all of that there. I'm not going to go through all of those because that's you can read those pretty easily.
So first, let's look at fictitious disorder. So fictitious disorder is going to come in kind of two uh, styles, we'll say. We've got imposed on self and then imposed on another. Well, we'll start with imposed on self, obviously. So this also used to be referred to as Munchausen syndrome. And I want to give you a little bit of a history about that name and why we don't actually use that name anymore. So Munchausen syndrome actually comes from a fictional character, Baron Munchausen. And this character was known for telling very exaggerated stories of his adventures. Um, Now, this was late 1700s, so this is pretty old. Um, in 1785, there was a book of Baron Munchausen's adventures that was anonymously published, and this was the first edition of the Munchausen tales. So you can kind of imagine that when we use Munchausen to describe this, we're we're not really too far off from the base, because eh, these symptoms tend to be, by definition, created or induced intentionally. But in using Munchausen, it kind of gives more of a derogatory association. So we kind of stemmed away from that and moved towards fictitious disorder. Okay, so let's look at these diagnostic criteria. Obviously, primary one is going to be falsification of physical or psychological signs or symptoms, or inducing of an injury or symptoms or a disease process that is associated with the identified deception. Um, they will present themselves to others as ill, impaired, or injured. So they're kind of living their deception. Um, we can also see that this deceptive behavior is evident even in the absence of um, external wounds. Now, that is most specific to, intentional causes of injury. We can also see that sometimes it's a severe, significant exaggeration of an underlying or previously identified um, medical condition. And then, of course, we want to make sure that it's not better explained by another mental disorder. And we definitely want to use our specifiers of if this is a single instant or if we have recurrent episodes. And recurrent is going to be anything two or more. Um, so,
And the other, honestly, more concerning form of fictitious disorder is when it's imposed on another. This is previously referred to as Munchausen's by proxy. And we'll talk a little bit more about the implications of this this disorder, but this is falsification, exaggeration, or intentional, um, essentially harm, I guess, being done to another person. So we do have a victim with this disorder, and so of course that can lead to some other issues that we will talk about.
now for some special considerations for this group of disorders, um, they are going to be more often seen in medical settings or primary care because, of course, they're going to be presenting and mostly concerned with their physical and medical symptoms. Um, I can't stress this enough, and I believe I have this in more than one place throughout this presentation, but just simply because we cannot identify a pathophysiological explanation or because a medical condition has been simply unrecognized, that's not grounds for application of any of these disorders. There are plenty of times that people do not present with the typical signs and symptoms associated with some of the well-known medical conditions. Again, we can also see that, just as I was talking about earlier with the with thyroid function tests, that within normal limits doesn't always mean that it's normal for the patient. So these are types of things that can potentially be overlooked by medical professionals. And then it would be kind of our job to rule out a psychological basis and get them to other specialists that might look a little more in depth in things. Um, I've kind of already talked about how we do have a lot of mental health disorders that are associated with somatic and physical symptoms. Um, a lot of times, patients that have been diagnosed with these disorders do actually have a pre-existing or a previously treated condition. Um, but I'm just noticing that recent is misspelled. Sorry. But it might not necessarily be sometime, in the recent past. Um, please ignore my typo on that. So sometimes what we see is that a pre-existing or a previously treated condition might actually be that trigger for the development um, of these disorders. Um, and then one more little piece of information. So hypochondriasis, that is a previous disorder that we had in the DSM-4. I'm sure you probably have all heard the term hypochondriac. Um, now that disorder has been kind of separated into somatic symptom and then illness anxiety, and we will talk about kind of how those look um, in just a minute. So we also need to be aware of some of the common comorbidities of these disorders, because of course, as we know, a lot of our disorders do not fly solo, if you will. So with somatic symptom disorder, we do have about 50% of folks that present with somatic symptom um, do also meet criteria for an anxiety or depressive disorder. Um, when this occurs, we generally can kind of expect a poor overall functional impairment and poor quality of life. Um, we also see PTSD, OCD. Sexual dysfunction seems to be mostly associated with men that have somatic symptom disorder, but that's not exclusive. Women can certainly experience that as well. And then a known medical condition. Um, when that occurs, we will see, like, if we have someone with somatic symptom disorder, but they also have a known medical condition, we usually do see that whatever condition that is, that the general outcomes of treatment and disease progress and process there um, are definitely worse when we have that. Now, for illness anxiety, primarily we're going to see OCD, panic disorder, depressive disorders, and there is a higher risk of personality disorders, but that's not necessarily a mutually exclusive type of situation. Now, it is important to just kind of take note that with illness anxiety, about two-thirds of patients that meet that criteria also meet criteria for at least one other mental health disorder. So we do have even higher numbers than with somatic symptom on those co-occurring. And then for conversion disorder, we've got our list there within anxiety disorders. Panic disorder tends to be the primary one. Um, Personality disorders are going to also be common with conversion disorder. Um, and it is pretty typical actually for folks that meet criteria for conversion disorder to also have another neurologic or another medical condition. Now, with factitious disorder, we really don't know because there's so many underlying and prominent, even deceptive behavior. So we really don't know a lot of the comorbidities as accurately as we would for our other disorders. Um, we do see that approximately 40% of these folks will also meet criteria for a depressive disorder. And then borderline personality disorder tends to be most commonly associated with factitious disorder. And then, of course, is associated with that poor prognosis. Now, what's interesting with factitious disorder is that when we see a comorbid mood disorder, anxiety disorder, or even a substance use disorder, there is an odd tendency that we might actually have a better prognostic uh, expectation, better prognosis just in general. Um, and as I record this, I have not seen the literature on why that might be. But I do guess educatedly that it could simply be because when we treat those underlying mood, anxiety, or substance use disorders, that the symptoms that we see of factitious disorder might actually decrease or potentially even resolve. Um, and that might make a whole lot more sense once we get to talking specifically about presentation of factitious disorder. Now let's look at the differentials of these disorders. So as always, anytime that we are evaluating any disorder, we want to know or at least be quite familiar with the differential disorders that we need to rule out before we settle on the diagnosis that we do. So for somatic symptom, primary thing we need to look at is if there are other medical conditions or psychological conditions that are affecting those medical conditions. Then we've got kind of our list um, of others, and then an additional one is malingering. Now, if we or I guess rather, if you guys haven't really been exposed to the idea of or this concept of malingering, um, it is essentially feigning severity, possibly even completely uh, creating symptoms or situations that are solely for uh, a secondary gain. Um, Sometimes that could be, attention, medical attention, um, maybe housing, things like that. So just be aware of what malingering is. For illness anxiety, we've got quite a few. Again, we also want to start off with ruling out any other medical conditions. Um, we also want to, and this is slightly different, than somatic symptom, we also want to rule out any psychotic disorders that have a somatic focus within that delusional content. Um, so, and that can be kind of difficult sometimes, but we definitely want to take a look at that. So, because somatic symptom and illness anxiety disorders are very easy to confuse, let's look a little more in depth at how we can kind of differentiate between the two. So, somatic symptom, it's the focus is on the symptoms. Now, they do authentically experience unchanging symptoms. Um, as I've said, and we will talk about more, pain tends to be a primary presenting symptom, and they do actually experience pain. Um, and that doesn't necessarily change. We might have a couple of various somatic complaints, but they really don't change too often. Now, when we compare that to illness anxiety, it's not the symptom itself, but the idea of the potential disease that they might have. It's very typical to see very few, if any, somatic symptoms, and those symptoms change each time that there's something presented. One day we might hear about a suspicious mole that is cancerous. The next day we might hear about a neurological condition that because there's some numbness going on, things like that. Now, for somatic symptom, it is actually pretty common for these folks to have a comorbid medical condition or a history of a previous condition. The disorder itself might actually be triggered by these experiences. Now, that's not necessarily required, but it is pretty common. Now, the symptoms of somatic symptom disorder are across the board unresponsive to medical interventions. And that's a very important detail here. In comparison, folks with illness anxiety disorder tend to not have comorbid medical conditions or history, but that doesn't mean that they won't. It's uncommon, but can happen. Now, the difference here in responsiveness to treatment is that most of the folks with anxiety illness disorder are found to have unconcerning concerns. And even when they are reassured by medical professionals that whatever their concern is not anything that requires treatment or any further assessment, that that you're fine, this is all kind of normal. That anxiety doesn't go away. Um, it might for the moment, but we will continue to experience anxiety about uh, medical potential medical conditions. Um, they also will see, or we will see rather, uh, fairly excessive medical service utilization. Um, I'll talk a little bit more about that when we get to clinical presentation. Now, with fictitious disorder, our differentials are a little bit different because one of the primary things that we have to do is we have to make sure that we have ruled out that this is deception to avoid any type of legal liability. Now, this is going to be mostly associated with people that are caregivers of others. And then, of course, we need to rule out all of these other ones, as well as malingering for secondary gain. Um, and then there's also that possibility that sometimes factitious disorder might really be the presence of a medical condition that doesn't really conform to how we typically recognize that condition. Um, and there are some good case studies that provide examples of that as well. And again, I'll talk about that a little bit more later on.
So here are our differential diagnoses that are or that need to be considered for conversion disorder, or prior to actually giving that diagnosis. We want to rule out these, make sure that the symptoms of conversion disorder are not better accounted for by uh, one of these disorders.
Now let's look at those clinical presentations.
So now with somatic symptom disorder, we want to remember that that primary, most prominent symptom is the somatic symptom itself, whatever that may be. Now that can be multiple, it can be changing symptoms, it can be one very severe symptom that's most often associated with some severe pain. Um, Tends to be non-specific pain, um, but it could also have a basis in a actual disorder that's going on. Now remember, just because someone doesn't have a medical cause that can be identified doesn't mean that that's enough to make this diagnosis. Um, and that's because we want to make sure that we're ruling out any potential causes. Um, I had a patient one time that was complaining of some very severe leg pains and would periodically lose function in his legs. And, you know, he went to probably 3 or 4 different specialists before he came to see me, and they, because they told him there's no medical condition that's causing this. Then, as it turned out, when I assessed him, I sent him for more testing. Um, and it turns out he had a pretty severe clotting disorder that just wasn't tested for. So we have to rule out everything. The most significant part of this is that the distress that's experienced because of the somatic symptom, um, that is the focus, not what could be causing it, not what is actually going on, but it's the symptom itself. Now, usually This disorder, we're going to see it first in medical settings. Um, and then once, a medical cause isn't found, then they usually will get transferred over for psychiatric evaluation.
So again, for somatic symptom, the focus for the patient is on the experience of the somatic symptoms, not necessarily what those symptoms could mean, but the experience of the symptoms themselves. Now, they're pretty commonly going to appraise their symptoms as cause for significant concern, even if a medical evaluation contradicts this. They might also just generally believe that their medical health is worse than it is. And again, as I've already said, those symptoms are going to be unrelieved by medical interventions. Now, I had a patient that, and I don't see this patient anymore, but she believed that a lot of her dizziness was being caused by a problem with her outer ear. Um, this went so far as to her essentially convincing some of her previous and then also current medical providers to remove portions of her outer ear. Again, that dizziness didn't go anywhere. I tried to explain to her that the dizziness was probably more associated with a combined situation of having Meniere's, which is an inner ear disorder that causes vertigo and dizziness, and that being exacerbated by her experience of anxiety. But that was not the case. She was not buying any of that from me. Um, and even when her medical professionals um, tried to explain the same thing, that was not, she was not having it. The dizziness was the problem. We could not get her to accept that her outer ear had nothing to do with that it was just something that occurred, that it was benign, that it wasn't really an issue, but she was convinced of otherwise. Now, with that, we also have to remember that distress and the physical symptoms that people experience are authentic. I didn't question whether this woman actually experienced dizziness. That wasn't that wasn't of any concern. The concern was, well, where's the dizziness coming from? But for her, it wasn't where's it coming from. It's the simple fact that it's happening was the problem. Now, again, with somatic symptom, they may or may not have an actual medical illness or condition, but it is pretty common that there's something going on there, whether it's current or past. Um, and so we just need to be aware. Eh, it may or may not be there. If it is there, we will tend to see some excessive focus on the symptoms that they're experiencing. Now, when somatic symptom disorder presents in a very severe case, um, those health concerns end up becoming kind of a central feature of their identity and definitely kind of dominate all of their interpersonal relationships. And this can progress to complete invalidism. And that obviously can be very difficult for people in their support systems to navigate and to handle. Um, but it does, like I said, it does kind of become a very central focus. Um, Again, I've already talked about this, but we will also see high levels of healthcare utilization, but the symptom itself is not going to be alleviated by that. We might see that they seek out multiple professional opinions, evaluations, different treatments. Interestingly, new interventions may actually exacerbate symptoms, and that is definitely an interesting feature of a somatic symptom. Um, and again, um, kind of recapping on this one, the symptoms of focus, for the most part, are going to stay the same throughout the entire course of this disorder. Now, as I said earlier, somatic symptom disorder and illness anxiety disorder are the two diagnoses that kind of came out of the previous diagnosis of hypochondriasis um, from the DSM-4. So if you understand that diagnosis, it's going to make this a whole lot easier to kind of grasp. Um, so one of the things that we need to recognize is that with illness anxiety, of course, it's not super common that we have physical or somatic symptoms present, but if they are, um, they tend to be assessed as within normal limits, benign or self-limiting, um, and just generally not indicative of any type of disease process. Um, that being said, folks with this disorder are not really eased by that anxiety about the possibility of something being wrong with them is going to remain. They also are very easily alarmed about illnesses. Sometimes even just simply hearing about another person being diagnosed with something or having some form of medical condition. And it kind of presents uh, subconsciously, um, possibly even consciously, as, oh, well, that person has this. I have this symptom. That seems like it might be that. I wonder if I have that one too. And this is kind of the thought pattern that occurs. We can also see that just general medical attention can trigger an increase in anxiety about potential uh, conditions that could be there. Um, a lot of folks with illness anxiety do have a general dissatisfaction with medical care because they do believe and feel that their medical providers don't take their concerns seriously. And this may or may not be true. Um, I definitely had a patient that she kind of constantly um, was concerned that she was developing cancer somewhere in her body. Now, this was a nurse that worked on an oncology floor. So obviously, we have frequent um, triggers of that anxiety. And anytime she would have a patient that had a similar early presentation or early symptom, she would then become anxious about it. And she, saw her primary care probably at least once a month to have labs done or to request imaging just to make sure that there wasn't anything there. And that would kind of alleviate her symptoms for the moment. Or alleviate her, her symptoms of anxiety for the moment, but then it would return the next time that she went to work and saw, more people, obviously with cancer. Um, Now that's kind of, unusual that it's always cancer for an illness anxiety, but just in her life, that was the thing. The symptoms would change, um, but it was always kind of this underlying, oh my gosh, I've got cancer. I'm so worried about having cancer. Um, Now, had Another patient that would fit kind of another presentation here, where he was referred to me because his primary care felt that it was, something psychiatric going on. And he had um, some fluctuating symptoms. Sometimes it was numbness, sometimes it was pain, sometimes it was stiffness in his legs. And superficially, he could have met, this illness anxiety disorder diagnosis. My gut feeling with him was that there actually was something going on that was being overlooked. And his primary care had kind of written him off because he did also have a lot of anxiety and some depression that he struggled with over the years. Um, and so didn't really send him for any further testing. So I had suggested, let's let's maybe see another professional. Um, and uh, turns out he had a pretty severe clotting disorder that he was experiencing the symptoms that he was experiencing because of an actual medical condition going on. And so this is kind of the worst case scenario fear of people with illness anxiety, that I have this symptom and it is a problem. So, two different takes on that. Now, again, just to kind of reiterate, obviously this is important information here. We will see that folks with illness anxiety, they are going to present more often in medical care settings because of that belief that they have some illness or condition going on. Um, Now, the illness focus is similar to what we see with somatic symptom disorder regarding the prominence in their daily life and how it affects them, their functionality throughout their day. And even with, just as we saw with um, somatic symptom, in severe cases, it can also lead to invalidism. Um, and that again becomes very problematic for patient and family or other support systems because here we are with recurrent concerns that there's some sort of disease process happening, and so they'll avoid certain activities or engaging in day-to-day life for fear of developing something or worsening what they believe might be an underlying medical condition. Um, Now it is, I guess, kind of as a side note, about a third to a half of people with illness anxiety disorder do have some transient symptoms, um, and in general, folks that meet this disorder criteria do have more comorbid medical conditions than mental illnesses. And so that we do need to kind of take note of that. But still less common for them to have comorbid medical conditions than folks with somatic symptoms. Again, a lot of this is kind of reiteration because of the importance of it. Um, Again, just because someone does have a medical condition doesn't necessarily rule out a coexisting or co-occurring illness anxiety disorder. We just need to really look at the level of anxiety and preoccupation um, regarding the medical condition that they do have. And that anxiety and preoccupation are going to be hugely disproportionate to the severity of the condition itself. And as I just talked about, we do have that transient um, presentation. Um, Now, we need to note that transient preoccupations with a specific medical condition doesn't necessarily support this diagnosis. Um, We do see that a third to a half have that transient form, but the specificity of the condition itself is inconsistent. Um, and that's where we start to associate this diagnosis. Um, and then just making sure that we're not applying our own biases to existing cultural beliefs. So we want to be very, very cautious if there is an underlying uh, known cultural belief that is kind of that common thread in the preoccupations or anxiety about illnesses.
With the possibility of encountering fictitious disorder, um, we do have to consider the very fine line that we might have to walk as clinicians in assessing if someone is intentionally causing the symptoms that are going on, or the medical process or disease process that's happening, um, or if this is actually happening and they need medical attention. Um, if we have this disorder and it is imposed on another, then the perpetrator is the one that's given the diagnosis, not the victim. The victim is most likely going to meet criteria for some form of abuse. And that might also include judicial involvement, legal authority, things like that, because there is someone else that is being intentionally harmed. Um, Years ago, I had a patient, a child, he was 15, no, he was like 13, and his stepmother had presented herself as his biological mother, and this child had had over 17 exploratory surgeries um, to evaluate the GI symptoms that he was experiencing that turned out to be not true. The stepmother was actually completely falsifying um, these reports. He wasn't experiencing any of the GI symptoms. She was just saying that he was. And because if he didn't agree with her or go along with it, then there were other things that happened at home that obviously he didn't want to experience. And so he just went along with it. He ended up becoming my patient when biological mom found out that this stuff was happening after years of trying to get or regain custody of her son. So that actually ended up with a whole legal uh, situation. Um, so some things that we can see um, is that we can have an exaggeration of real symptoms. We can have complete false report of symptoms, like what I just exampled. We can see people actually manipulating lab tests um, in order to mm, fake, I guess, in a way, um, the symptoms. Um, Probably worst case scenario in this is when someone intentionally causes an injury in order to gain or in order to receive that secondary gain. Um, and especially when an intentional injury is caused uh, to another person. Um, it's kind of a scary one because we really want to make sure that our patients stay safe, whether it's from someone else or from themselves.
And for a factitious disorder, one of the requirements of having this disorder or applying this disorder is that we identify that a patient is clearly demonstrating this surreptitious behavior and actions in order to misrepresent, simulate, or even cause signs and symptoms of a particular illness or even injury. Now, the external rewards might not necessarily be able to recognize what those are. Um, they might even be absent. But the motivation, the rewards, isn't necessarily even a focus. Um, it doesn't really matter what the motivation is. The fact that the deceptive behaviors are occurring is the key to this diagnosis. Now, um, we can also see that sometimes people with this disorder don't actually present to medical professionals for evaluation or treatment. Um, it's just simply that they misrepresent or mislead their support systems or even their family and community um, with the presence of illness or injury. Um, for the most part, we will see factitious disorder kind of be an intermittent, episodic presentation fashion. Um, Having a singular episode or a persistent, ongoing episode can happen, but they're much less common. Um, one of the triggers, I guess we could say, for development of this disorder has been recognized to be the hospitalization or treatment, intensive treatment typically, or a serious injury of a dependent of theirs. Now, that could also be hospitalization of themselves or a serious injury. But more typically, we will see this present after this occurs with a dependent under their care. Um, a very concerning feature of that is that there is that possibility that subsequent episodes, well, I guess really not really subsequent episodes. It would really kind of be the emergence of episodes um, in the future might actually be attempts to cover abuse or neglect, where the initial triggering episode or event was not necessarily intentional. And the next couple of slides are examples of the most common presenting symptoms of conversion disorder, along with some of the most common inconsistent findings on exam. So first up, we've got muscular weakness or paralysis. One of the things that we might look at, and again, this isn't these findings, these exams, these tests are not necessarily things that we're going to do as psychiatric providers, but we might see in their medical record that these tests have been done. So first up, with muscular weakness and paralysis, we're going to look for Hoover's sign. Hoover's sign is specifically a weakness of the hip extension that returns to normal strength when contralateral hip flexion is applied against resistance. Um, we might also see a discrepancy between weakness of the ankle plantar flexion when we manipulate that on the bed or on the exam table versus a person's ability to walk on their tiptoes. So those are going to be very inconsistent. They don't go together. Um, One of the other ones when we're talking about paralysis is recurrent transient paralysis. As we know, paralysis is pretty consistent. It's pretty much a constant thing. If we are paralyzed, we are paralyzed. If we regain function, then we regain function, and we're not going to slip back into paralysis. I had a patient that did this exact thing. It was a hemiparesis where she would lose the ability to walk, um, and that would come and go. Um, we've done pretty good to resolve that at this point in time after many years of doing therapy and uh, dealing with her anxiety and depression. Let's see. Then we've got a functional tremor. So with this one, we're going to see contradicting results through this tremor entrainment test. Um, Now, this is when the tremor is going to change when the patient is distracted by trying to copy the examiner making rhythmical movements with the contralateral hand or foot. Um, and that's definitely an interesting result. Um, that the change in the tremor could be that it's completely suppressed, or that the patient can't copy simple rhythmical movements. Um, Either one of those is going to be indicative of a conversion disorder basis here. Then we can have functional dystonia. Um, and this is kind of interesting because usually it's going to be unilateral. And as we know, when we have dystonia, it's going to be bilateral and kind of across the board. It's not just one, it's not just going to be one side or the other. Um, and we will see it most commonly with these fixed inverted positions unilaterally, ankle, fist, or platysma, and that's the superficial anterior neck muscle there in the front. And then we've got functional or dissociative non-epileptic seizures. Seizures, they go by quite a few different names. I know when I was learning about them, we referred to them as pseudo seizures. Now this can be mimicking of epileptic seizures or possibly even just syncope. Um, and these are the signs that we're going to see that are going to like really pop those red flags that we're not dealing with a neurologic uh, source. Um, Now, I will also say that in order to make the diagnosis, it's not just going to be these symptoms here or these signs here. We're usually going to need a supportive normal ictal EEG. So Um, for visual symptoms, functional visual symptoms, we're going to use that fogging test. And basically, what we're doing here is it's kind of sneaky, but it's a way that um, we can say that the bad eye is actually functional when the good eye is fogged so subtly that the patient doesn't really notice it. And then we've got abnormal movements. There's not a whole lot of specific testing for those other than what I've already talked about, so I didn't really go more into that. Um, we can also see sensory symptoms, so alterations in skin sensation, generally vision, already talked about, sometimes even smell or hearing. And another sensory symptom that goes along with vision is going to be that double vision. Um, and that's one that we just need to look out for that one. With speech symptoms, though, um, we're going to see inconsistencies kind of across the board, really, with uh, speech patterns and just general articulation. Um, Maybe even in volume control or volume of speech in general. And then another one that falls on this list is that sensation of having a lump in the throat, that globus. Um, and when we can't really find any medical explanation for any of these things happening or uh, reproduce the symptoms, that is, with normal and usual evaluation methods, then that might be when a medical professional is going to say, okay, we might be dealing with a conversion disorder here. Um, it is important to note that sometimes we might have mixed symptoms where we have a combination of all of these or a couple.
So one of those is pediatric psychogenic non-epileptic seizures. Um, and this is a type of conversion disorder. And basically what happens is these are what we would also refer to as pseudo seizures. We might be used to hearing that term as applied to adults, but this is specific for children. So, from a psychodynamic perspective, the development of uh, pediatric psychogenic seizures is, in essence, it's a unconscious or subconscious avoidance of situations, people, what have you, that trigger extreme negative emotions. Um, the kids are unaware that they're doing this. Um, and a way that we can assess the insight that a child may have is um, children that experience these tend to have difficulty uh, verbally describing their emotions, especially negative emotions and in general their thoughts. Um, the theory goes on to explain that when these negative emotions accumulate and the problem doesn't go away, and we still have that repeated exposure to the trigger or the stimulus, um, it kind of builds, and then we end up seeing this. Um, the I guess kind of the situation that occurs that might perpetuate um, this this type of conversion disorder is that we do actually end up seeing a type of reward happening because whenever the child has one of these seizure type events, they end up being excused from meeting any of the demands or uh, the demand of sorry, the demand of engaging with or yeah, just engaging with a negative situation, whatever they term as negative. Again, they might not necessarily recognize that though. And one of the things that we see as a is kind of a primary accepted situation that can bring on these types of seizures is family discord, unrealistic academic or sport-related expectations, bullying, and rarely physical or sexual abuse. We don't usually see this as associated with that, but there's definitely been cases. Um, and you could see how if a child is exhibiting seizure type activity in any of these situations, then it can actually bring a halt to the experience of those situations. Now, we've got two independent risk factors that can help us to differentiate, um, and it's uh, somatic, somatopsychiatric factors, don't know why my mouth wouldn't say that, and adversity factors. So our somatopsychiatric factors are going to be medical problems, excessive use of medical services, and fearful responses to physical sensations. So we can start to see a lot of anxiety that develops with these kids about medical things. And then the adversity factors are bullying. Um, we do also see an association with just emotional dysregulation um, and expression issues. Um, Pretty much any type of psychiatric disorder, and then treatment with psychiatric medications, actually. So, how do we diagnose this? How do we differentiate this from actual uh, seizure activity? Well, of course, first we're going to do an EEG. A lot of times, EEG is not going to pick up any seizure-like activity because seizure-like activity or seizure activity isn't actually happening. Um, but yet, the seizure activity continues externally. Now, of course, we've got to keep in mind that EEGs don't always pick up seizure activity. So that doesn't necessarily rule out the diagnosis of epilepsy, but it does indicate that there's a need for further evaluation. Now, about a third of children with epilepsy would also meet criteria for psychiatric or psychogenic seizures. This is basically the assumption that we have a very well controlled epilepsy. We're not seeing any seizure activity. None of those things happen, but yet we still have a lot of breakthrough seizures, um, and that's kind of a red flag. Um, for any child with a new onset of seizures, and this is kind of a big red flag, for any child with a new onset of seizures, if the seizures don't respond to two anti-epileptic drugs, then it's assumed that the child has intractable seizures. Now, that is concerning because if we also have that response, and we're saying, okay, now we have intractable seizures, but we're still not picking up anything on the EEG, problem. That is going to be a problem. That is a red flag. Now, a lot of times parents will have a lot of difficulty recognizing or admitting that their child has any social, learning, or psychological difficulties. So we really have to be empathetic um, to the perception of parents in these situations. Um, on the flip side of that, parents might interpret these seizure type episodes as attention seeking, or just trying to get out of something, and then they'll say, oh well, that's nothing, we're not going to worry about that. That can also be problematic. Now either way, um, the responses by parents can actually perpetuate the behavior. So if they give too much attention or don't give attention, it can actually increase the experience of this unintentionally. Now, the child themselves might actually minimize or downplay um, any issues or any underlying issues that they might be having with feeling anxiety or depression, sadness or stress, things like that. So we always want to uh, fully evaluate the presence of any psychiatric symptoms. So here's just a list of the big red flags. Some of them I've already talked about. Um, and I'll let you kind of read those over yourself. Um, Now, a couple of red flag uh, clinical manifestations that I do want to point out here um, is that if you've ever seen a seizure or experienced a seizure, we know that this is a very sudden situation that happens. But with a child with psychogenic seizures, might actually have a gradual buildup and start with hyperventilation that would typically look more like a panic attack coming on. We also know that we have that post-ictal period after a seizure. Children don't know that. So if they don't actually experience seizures, then they're not going to have that post-ictal period. Um, Also, if they never happen when the child is alone, that's a big that's a big kind of manifestation red flag, um, because obviously we know that seizures can happen when no one is around. Um, then we also, of course, will have injuries that can happen during an actual seizure that don't happen with this, and now, not that it happens every single time with a seizure, but we know that incontinence is common with epilepsy or actual seizures. With a psychogenic seizure, that's not going to happen either. Now let's round out this lecture with our etiology, prevalence, and some of our risk factors in this group. So first up, let's look at somatic symptom disorder. So the prevalence of this one is got some pretty good variation. In general, when we're looking at general population, if we combine both European and North American research, the estimate is somewhere around 4 to 6% within the general population, which is for mental health disorders is actually pretty high. Now, if we combine adult and adolescent numbers, then you can see that can be actually significantly higher than that. And that could be due to the fact that a lot of children and adolescents tend to be very somatic just in general, um, and experience uh, emotions on more of a somatic level. So that could be the situation there. Now, I also want to say that uh, along with all of this, we do also have a significantly higher risk of suicide uh, for somatic symptom disorder. We really don't know if, because it's pretty unclear, honestly, but we really don't know if this is due to the association with depressive disorders, which
somatic symptom is most associated with depressive disorders, or if it's due to the somatic symptoms that never go away. So, not sure, but definitely still that increased risk. Now, when we look at risk factors for development, um, we see that within our temperamental risk factors, um, there tends to be fairly consistent negative affectivity, also called neuroticism. Um, and then again, that comorbid depression, which is most common, but also with anxiety disorders. In our environmental factors there, we've got a lower educational level, lower socioeconomic status, and then also a recent experience of stressful life events. These things are going to put someone at a higher risk for developing and or meeting criteria. Um, we also have some other notable risk factors here. When we look at just some of the most associated and higher risk demographics, and then also our gender differences, we do see that the highest risk is the highest risk population, I guess, is going to be someone of female gender, um, older age, fewer years of education, lower socioeconomic status, and also being unemployed. Now, when we talk about female gender as being associated with a higher risk, that's because women in general do tend to report more somatic symptoms when compared to men. Um, and often the experience of somatic symptoms is more severe as well. Um, we also have the other list there. The one that I really want to talk about along with this is that reinforcing social factors. What we mean there is what are the benefits that someone experiences to being ill? Now, that doesn't necessarily mean that we're dealing with malingering, because that's a completely different issue. But if someone is excused from work or has a lighter workload, or they are treated differently, then that is actually going to be consider those social reinforcing factors that unconsciously um, provide a type of motivation. Now, again, that's an unconscious thing. This is somatic symptom. This is not something that someone is making up. All right. I want to make sure that that's very clear. Um, Then when we look at cognitive factors, how sensitive someone is to pain. Again, that kind of goes back to a gender situation. Um, Heightened attention to bodily sensations, and then a poor recognition of the significance of those bodily sensations. That is going to be uh, a highly associated um, situation, an experience that puts folks at that higher risk. Now, for illness anxiety, again, well, not again, I guess. So all of these rates are actually based on the previous hypochondriasis diagnosis, because there hasn't really been a whole lot of research and literature produced focusing solely on illness anxiety. So we see a range of anywhere between 1.3 and 8%. On average, we're looking at about 3%. Now, in specialty clinics, that's going to be a much higher percentage at about 20% prevalence rate there. No noted gender differences in prevalence rates at all. Um, Now let's look at our risk factors for illness anxiety. They're actually kind of limited, and they are pretty solely environmental risk factors. So again, we do see that illness anxiety, just like somatic symptom, is often precipitated by a major life stress or a potentially but ultimately benign health threat. And this is going to kind of set someone up to be concerned about another potential um, serious medical condition. Now, we do have some predisposing factors or predisposing environmental risk factors, and that's going to be childhood abuse and serious childhood illness, very similar to somatic symptom. Um, but then we also have a serious illness or a medical condition that led to or was related to the death of a parent or another primary caregiver. Now, this is slightly different than the somatic symptom um, environmental risks. For conversion disorder, um, prevalence, well, we really don't have a clear picture of that um, because we have that transient functional neurological symptoms that are actually pretty common. Um, so we really don't know, but we do have some notable incidence rates for persistent conversion disorder symptoms, and that ranges somewhere between 4 and 12 out of 100,000 per year. And then if we look globally, prevalence within neurology clinics, uh, another wide range, but somewhere between 5 to 15%. Excuse me. When we look at gender differences, in general, conversion disorder is more common in women by about 2 to 3 times. Um, However, there are some differences even within that. So, conversion disorders that lead to cognitive impairment or include rather cognitive impairment and weakness are more common in men. And then we do see higher rates of uh, predisposing environmental factors of sexual and physical trauma as being more common in women. Going even further in our risk factors for conversion disorder, for our temperamental factors, generally emotional instability and other maladaptive personality traits that kind of go along with um, emotional management and coping is a primary one there. Now, for environmental, I kind of already talked about childhood abuse and neglect in as being more prevalent as a risk factor with women. Um, but generally, stressful life events are pretty common, but that's not necessarily universally triggering. So that is kind of on a case by case basis. Now, for genetic and physiologic risk factors with this one, um, there actually is a pretty high percentage of folks that have a diagnosed and recognized neurological disorder um, that has similar symptoms to the presentation of the conversion disorder. Um, for example, about 20% of people with non epileptic seizures also have been diagnosed with epilepsy. For factitious disorder, lots of unknowns on this one. And of course, that's going to be primarily due to the role of deception in this disorder. Um, we also have a lack of recognition and or recording of the diagnosis by healthcare professionals. There are plenty of case studies out there that someone in a retrospective evaluation met criteria for factitious disorder, but it wasn't recognized or even diagnosed. But all of the symptoms were recorded. It just wasn't, the diagnosis wasn't given. Um, there's been a couple of studies that kind of have led to what little prevalence information we do have. One of them was, or one of them kind of led to a approximate 1% of uh, folks meeting fictitious disorder imposed on self um, within general medical inpatient admissions that had been referred for psych consult. Um, there was also a study done um, in in Germany of 241 primary care and subspecialty providers that found a prevalence rate of about 1.3%. So that, that kind of brings us to that. Now, interestingly, there was another study that was done looking at 100 consecutive admissions to a specific psych ward in New York. Now, within that, they found a prevalence of about 6%. Um, so again, that range, we really don't know any firm uh, numbers on prevalence, but we could say somewhere around 1% in general population, and maybe as high as 6% in inpatient uh, facilities. Now, for fictitious disorder imposed on another, that usually isn't recognized or even really encountered except in those tertiary care clinics. So that's in and of itself kind of problematic because it gets to that point before uh, it's recognized. Now, for demographics, if we were to say who is the highest risk population, we're going to see early adult to middle age female that is employed in the healthcare field and is unmarried. So those are going to be our highest risk factors. Now, when we talk about etiology, because this is always where the questions tend to focus, is why would someone do this? It is largely speculative and only based on observation. And all of the information that I'm going to provide on this actually came from a Stat Pearls um, publication. About 60% had a major childhood illness um, and probably had some sort of learned um, benefit uh, from being ill. Um, they are also more likely to have experienced a difficult or traumatic childhood. Most commonly, this is going to be associated with emotional and physical abuse. And there's some developing theories of the association with personality disorders, but we really don't have a very clear picture, but there's definitely a correlation there. Now, some other factors that could explain the development of fictitious disorder is the affection and attention gained from being either in the sick or caretaker role, um, possibly in efforts to seek out and then also maintain relationships. Um, there is kind of going back to that development of personality disorders. There is a possibility that dependent personality disorder could um, be a factor within this one. Um, then we've got just enjoyment of being cared for by others or the need, the subjective need to be cared for, ineffective coping skills to stressful life events, a lack of self-identity. And this one's kind of interesting because what we see here is that the identity of the person becomes that of a sick person or of a caretaker. And so outside of that, they don't really have a firmly developed or significantly underdeveloped um, self identity and self concept. There's also this notable sense of accomplishment when they have fooled us. Um, and that one's definitely interesting. Um, we'll see how that one kind of plays out in the association to other personality disorders as those theories continue to develop. And then finally, we do also want to kind of look at the possibility of some sort of pathophysiology or psychopathology associated with pathophysiology. And for the most part, we can't really identify a specific medical pathophysiology. Um, it is important to remember that deception is a normal human behavior, and it is very normal for people to exaggerate the symptoms that they experience um, to gain attention or for some recognizable reward. Um, but kind of the line is most people don't intentionally induce exacerbations or cause symptoms. And that's kind of the line of between normal and abnormal in deceptive behavior. Now, I did find a study that uh, it was kind of more of a case study of only five diagnosed individuals, but they did find some common traits um, in those five individuals that we could cautiously generalize, and that would be above average and even excellent intellectual and verbal skills. However, a lot of deficits in conceptual organization and judgment. Now, those that kind of group of common traits led to a hypothesis of right cerebral hemisphere dysfunction. And this was notable in results that indicated this list here. We've got hyperperfusion of the right hemithalamus, um, pathological evidence within EEG results, and then also some mitochondrial disorders. Um, and mitochondrial disorders could account for some of the deficits in conceptual organization and judgment. Um, but the others, it's kind of questionable. The, of course, the thalamus we know is, regulatory of uh, the sensory input and then um, associated emotional and behavioral responses um, after uh, processing through the cortex. So if we have some hyperperfusion of the right hemithalamus, then there's a possibility that there is some sort of dysfunction within that system. Um, so there you go. And this is going to conclude this lecture. As always, let me know if you have any questions or need any clarification on any of the content that we covered.